know, with today's insurances, there's, to the patient, there's minimal pay. I'd say we go through specialty pharmacies, which are very popular today, such as City Drugs.
I heard of them.
They're very good, and we actually use them all the time. And those pharmacies, they work with the patient, they work with us, and honestly, together we come up to the approach to that patient, and sometimes we provide even a service to them to, go to their house, or whether to call them to check up on them, and the medications get delivered to them, because this is very important. That medication has to be taken at that time. So the pharmacy plays a very important role in the treatment of these patients. That's why we're very careful of who we work with.
Is there any prevention from getting these diseases?
In terms of prevention, so certain people do have predilection to have, let's say, Crohn's disease or ulcerative colitis, mainly if their family members have it. Otherwise, most people do not know. You cannot tell whether you're that patient, that person that's going to get it. Now, there is prevention from complications from these diseases, and that's actually a key aspect of gastroenterology today. And we are basically a field that's in preventative medicine. We're trying to prevent colon cancer. So if you look at patients with inflammatory bowel disease, at a certain point in the natural history of the disease, we have to start looking at the possibility that they could have colon cancer. Mainly because these are diseases that are constantly changing the lining of your GI tract. And as you know, when you kind of slough off the lining, the cells have to divide to form new lining. And every time there is multiple divisions, there's a chance that something could go wrong. You have a mutation. And these patients have a lot of divisions. They have a lot of random mutations. So they need constant screening. They need constant screening for colon cancer. And when I say screening, I mean colonoscopies. They tend to get colonoscopies every 1 to 2 years. But again, these tests are today a breeze. We have preparations that are very easy to take. They're not as big as previously, which used to be a 4-liter bottle.
This big.
Correct. And I also always show the patient, because they go to me, "Oh, doc, I got to drink that thing." But no, we have things like Soup Prep or Plenview. These are much easier to take. These are about 1/4 to half of the size. The patient keeps a specific diet the day before. You cannot prevent them from getting diarrhea. But believe it or not, it's actually much less than previously. They come in the morning. They meet the team. We have some music playing for them. They get the medication. They fall asleep. The test is done between 20 and 40 minutes. They come out. They eat something. We go over the results. And if we do find something, almost 99% of the time, if not more, we could fix it right there on the spot. So that is how we prevent with this. And it's the same way as we prevent colon cancer in terms of the general population, how today people get colonoscopies. The age seems to be fluctuating, seems to be getting better, lower and lower. It used to be 50. Today there are some studies and some societies that are recommending 45. And these are basically colonoscopies done on patients that are coming into us without any complaints. They don't have any medical problems. They don't have any issues of inflammatory bowel disease or irritable bowel syndrome. They're just here, "Hey doc, I'm here. Make me healthier. Make me live longer. Keep me more kind of in tune." And we do a colonoscopy basically. And we're looking for polyps. Polyps looks like, in a way, like a bump. And when we see it, this is the precursor, this is the precancer. And the chance of a patient having one at the age of 50 is anywhere from 20 to 30%.
But they could have the family history, like you mentioned before, right? So
Correct.
They just want to be preventative.
Correct. And if they have a family history, believe it or not, most people are coming with family history about 10 years from the time that the youngest relative was diagnosed, which is usually around 40 years old.
I have a few more years, okay.
You have a lot more years, I think. And,
So what made you choose GI? Because, I mean, everyone would have, like even when you have the colon, would you refer that to a proctologist or do you take care of it yourself?
So, GI was, for gastroenterology, the road was a little bit on the longer side because after med school, we have to do first general medicine. So we have to do 3 years of internal medicine training. And during that time, you could choose anything from cardiology to oncology to endocrinology, and gastroenterology was an option. But to tell you the truth, this field was, to me, it fit me the most because this field had both objective evidence of disease, such as you would see with surgery, which is, let's say, a colonoscopy or an endoscopy, where you get to right there to the problem, and whether you could diagnose it through biopsying or you could take care of it right there and then by removing the lesion. And at the same time, you have all the patient contact that you want because you're still a medical doctor, you're still sitting with that patient, you're still hearing about his family, you're still hearing about his future, his troubles, what his problems are. And that was a field that offered, everything to me.
So you really care?
I try, and I'll just say it.
Because some people become the doctor that they want to become, and they forget why.
I agree with you. And hopefully
and your group is different.
Right. We strive for that, and we have, we always have meetings. We always discuss our complicated patients. We always try to have a meeting and see, if there's someone is not sure what to do. Well, we have 5 other opinions of what we think is right, and then we could come up with a consensus.
Everyone begged me to ask this question, so I'm going to have to ask you. Abdominal pain, can it come from someone that just started the gym to pregnancy? Can it come from genetics? Can it be a disease? What could be the cause of just abdominal belly pain?
It's a very good question. And this is a question that we get thrown at probably 20 to 30 times a day. And it goes just like that. We do have somebody that comes in who started working out, and he gets, abdominal pain.
I get that.
And you work out a lot. And the gastroenterologist, yes, you have to be able to differentiate, and it's very important because the last thing we want to do is do unnecessary tests. So, and the abdominal basically area, which is right here, yes, you go kind of from the outside to in approach. And abdominal pain, yes, musculoskeletal pain can easily be a spasm after working out, or if you didn't notice that you were kind of sleeping on the wrong side, or you were hit at a certain point, or you stretched the wrong way, and then you go towards the inside. Well, does this patient, is it somebody that has overweight and they could develop, cholesterol stones in their gallbladder? Or is this somebody that's a heavy alcohol user and he may have developed pancreatitis? Or is it somebody that, went yesterday and ate the wrong, raw fish and got
sushi.
Sushi is very popular today. It's kind of hard to get away from. And basically somebody that developed, your gastroenteritis, but gastroenteritis can be presenting in multiple ways. It doesn't necessarily have to be vomiting and diarrhea. They could just be having bloating and generalized pain. So what you do is you take a history and then you decide on the test. The patient leads you. The patient's story is the key. And that's why you have to spend an appropriate amount of time and get the correct history. And then you decide, well, fine, do you need blood work? Do you need to check his liver markers or markers of pancreatic disease? Do you need to take an X-ray or a CAT scan? Or do you go for an endoscopy? And basically, are you worried that this patient has a stomach ulcer and you need to take a look, immediately and basically treat it right there and then on the spot? And this is how we would tend to approach it.
So what are your typical patient ages like, would you say?
Well, we're adult gastroenterologists, so we tend to see patients anywhere from 17 to 105. And yes, it's true. Every decade or every age group has its own problems. But we do, in reality, in our group, we're able to treat pretty much anything and everything. And if there is something that one is unable to do, you always have another subspecialist in the group that could treat it. And we typically, I would say our ages are from 40 to 60 years old, mainly because colon cancer prevention became such an important topic, such an important fact in our medical community today, that and physicians, whether it's in the community, internal medicine physicians or other gastroenterologists or surgeons, are becoming much more aware and cognizant of it, and the patients are coming pretty much starting at 45 and saying, I'm here.
It's funny you mention that, because the biggest thing was pharmaceutical industry has really pushed the colon cancer screening.
Correct.
You think that's a part of it too?
That, the pharmaceutical industry, of course, has its own agendas, but the pharmaceutical industry mainly makes the bowel preparations. But in terms of colon cancer prevention, that's mainly based on studies, mainly based on NIH studies, and studies that basically have shown a difference in life expectancy, shown a difference in morbidity and mortality for these patients. And the chance of basically, if the chance of you having a polyp is about 35%, and the chance of you, and I'm not trying to scare you, your chance is much lower, but a chance of, let's say, a 50-year-old male having a polyp is 30%. And if you could get rid of that polyp right there and then, and his life, the prevalence of colon cancer is, let's say, 8%, well, you just did that man a big service.
Thank you for your interest in the show and your desire to become involved and educated. I invite you to visit our website at www.medcastplus.com and check out our tools and connect with us on social media. You can also call us at 718-510-2103. Please stay well, go to the doctor, get yourself checked, and be safe, and goodbye. Thank you.